Good morning. We have just started the webinar. Thank you for joining us. This is the California Elder and Disability Justice Coordinating Council, or EDJCC. That's the acronyms for this meeting, EDJCC. This is our first meeting of 2026. Today is March 5th, and we are just about at 10 a.m. and the meeting's slated to go till 1. So thank you for joining us in this virtual space. I will introduce myself. I am Carol DeAndres. I am the manager for stakeholder engagement here at the with the Master Plan for Aging, MPA, at the California Department of Aging, or CDA. So a few logistics where we have meeting accessibility functions. We are so glad to provide them. As you can see, we have ASL. Our Bailey and his partner will be providing ASL interpreting. You also have closed captioning available to you. So to initiate that, you should have a CC icon with your Zoom toolbar. If not, feel free to check those 3 dots, more options. Sometimes it's hiding behind there. Show captions, view transcript, and you will have closed captioning available to you. Next slide, Callie, thanks. Following this meeting, you will find the meeting slides, the recording, any materials posted to our California Health and Human Service Agency, or Cal HHS, to our EDJCC webpage. So check there in a few days. Council members, right now, if you've just logged on, your Zoom display says EDJCC member or guest, and this is for our guests as well. Please rename yourself to your name and to your organization if you like, but we would like to know who has joined us on the webinar side. So we appreciate your assistance in that. And while the meeting is in session, please turn on your video so we know that everybody is here and participating. If you have trouble with your video today, feel free to drop a message into the host and co-hosts, and we'll note that. Technology is helpful, and sometimes it's not. So thank you all for renaming yourself and turning your video on. Next slide. The virtual meeting operations. The chat function is enabled for our council members, CDA staff, and our invited guests to share out meeting-related resources and information. And the public, our public viewers, are able to view that content in the chat. The chat and question and answer function are not enabled for questions to from public attendees, but we do have a public comment period where you can orally give public comments. I believe that is towards the end, around 12:45. So we appreciate your holding your comments until that time. But at any time, you can submit written comments to the California Department of Aging, and we'll make sure that it gets to the committee at engage, ENGAGE, at aging.ca.gov. Again, anytime you can submit written comments to us to engage, ENGAGE, at aging.ca.gov. Just a few comments about our public comment period, about 12:45 today. For those of you attending by phone and wish to give a comment, you would press *9 and it would indicate to us that you have a comment, and we will unmute your line. And for those of you attending via the Zoom webinar function, and if we can have folks make sure that their line is muted, and if team, you could go through and do that, that'd be great. Thank you. Attendees joining by the webinar function, you have a raised hand icon, and go ahead and use that, and that will indicate to us, and we will unmute your line. Do note that we have 2 minutes per commenter, just to make sure that we have enough time for all participants to give comments. So, and again, anytime you can submit a written comment, email it to us at engage, ENGAGE, at aging.ca.gov. And now I'd like to introduce our legal assistance developer here at the California Department of Aging, Rajana Maharaj. Good morning.
Good morning. Thank you, Carol. Good morning, everyone. My name is Ranjana Maharaj. I am the legal assistance developer here at CDA. It's truly a privilege to be here today as we come together for our very first 2026 EDJCC meeting. So before we delve into today's agenda, I'd like to take a moment to revisit the council purpose and equity guiding principles. Thank you, Kelly. The goal of the Elder and Disability Justice Coordinating Council is to increase coordination and develop recommendations to prevent and address the abuse, neglect, exploitation, and fraud perpetrated against older adults and adults with disabilities. Next slide, please. We recognize that past and current interventions and services intended to prevent mistreatment have had negative consequences for some victims, families, and communities as a result of systemic discrimination and biases. To counter these negative impacts and to ensure equity and inclusion moving forward, we're committed to letting the following principles guide all aspects of our work in planning, coordination, and program development. Next slide, please. 1. We recognize that all adults deserve to live free from abuse, neglect, and exploitation. 2. We acknowledge that the existence of systemic racism, discrimination, and negative impacts. In order to combat its impacts, we must center equity at all stages of our council's work. 3. Centering around equity does not just mean creating equitable solutions for all older adults and adults living with disabilities, but also recognizing that implicit bias exists within all of us. We're committed as a group to acknowledge and explore biases while doing the work of this council. Next slide, please. 4. We acknowledge that while older adults and adults living with disabilities have many overlapping interests, there are distinct communities, and any policies that are observed or recommended by this council should examine impacts to each community. 5. We recognize the importance of hearing directly from older adults and adults living with disabilities. Their lived experiences should always be centered as we move forward with the work of this council. And just to mention, our council serves as a platform for collaboration, innovation, and exchange of information. And we're here to amplify the voices of older adults and adults with disabilities, identifying systemic gaps, challenges, and make thoughtful recommendations to help protect their rights. So with this purpose in mind, let us proceed with the next few slides. Thank you, Callie. On the next 4 slides, we'll see our EDJCC current and new members. We're really excited to have our new members on board. I want to thank each and every one of you in advancing elder and disability justice across communities in California, and it's deeply appreciated. And the work continues to inspire and drive our shared mission forward. Thank you, Callie. Next slide. Thank you. Let's quickly walk through today's agenda. We started with welcome and meeting logistics, followed by a review of our council's purpose and guiding principles to ground our discussion and framework. At 10:15, we'll hear opening remarks from our state co-chair director, Susan DeMorris. Then at 10:25, our stakeholder co-chair Bertha Sanchez Hayden will welcome our new EDJCC members and new subcommittee chairs. At 10:40, we'll move into strengthening adult abuse reporting and response systems with a focus on cross-agency collaboration and systems alignment, followed by older adult behavioral health project at 11:05 a.m. We'll take a short break at 11:25 a.m. Next slide, please. Thank you. And at 10:15, at 11:40, we'll hear from the state long-term care ombudsman updates, followed by Aging and Disability Lived Experience Advisory Board, also known as ADLIB. At 12:10, we'll discuss midpoint evaluations for the Master Plan for Aging, followed by EDJCC discussion and recommendations to the California Health and Human Services Agency at 12:25. Public comment opens at 12:45 and we'll close with final remarks. So without further ado, I'm pleased to hand it over to our state co-chair, Director Susan DeMorris.
Thank you, Ranjana, and good morning, everyone. I don't know if you caught the change in Ranjana's title. We're just thrilled that she has been named the Legal Assistance Developer for the Department of Aging, and she'll be working between our Master Plan for Aging team and our Office of Legal Services and continuing to lead this group. So congratulations, Ranjana. You're exactly where you're supposed to be, and we're so happy that for this change in your role and your title. I wanted to, even though it's spring in Sacramento, this is our winter meeting. We're still in winter. And I just wanted to acknowledge, right up front that the work of elder and disability justice is hard and it is unrelenting. And I just want to thank every council member who joins us today. We find energy and inspiration when this group comes together. And so I want to thank everyone who commits their time to this group. I want to especially welcome our new council members. And I want to thank our returning council members for coming back and continuing the work. And I want to acknowledge my co-chair, Berta, stakeholder co-chair, as well as Jason and Alicia, our two new subcommittee chairs. So the leadership is just outstanding in this group, and running through the slides of everyone who's joining us, all corners of our state, all types of organizations, varied interests, but a common purpose. So welcome to everyone today. I also want to acknowledge our partners in this work and our collaborators, other state departments and agencies. Today, I know at the start of the meeting, we have Department of Developmental Services and Department of Social Services represented, and others are joining throughout the day. So a special thanks to our state partners. And let's see, I wanted to, and also we're going to share with you that we did just release at the end of January. I hope most of you have seen it by now, the annual report on the Master Plan for Aging. And Ranjana's role actually ties to one of our initiatives there. It's Initiative 61. And we're really looking forward to building off of the work that Justice and Aging and Beth Zedek did in consultation with CDA about legal services through our AAA network. So that's going to be part of Ranjana's role, working with our 33 area agencies on aging. So you've got the MPA annual report in your chat if you haven't seen it yet. And then I'm especially excited that we have agendized today older adult behavioral health. And there's such a strong nexus with elder and disability justice and the work that's happening with Proposition 1 and the Behavioral Health Services Act. And you'll be hearing from a familiar council member and leader in this space. Vivian will be sharing work that's underway around older adult behavioral health. And I'm just so pleased that this is on the agenda and that we'll be focusing our attention as an advisory council on older adult behavioral health. So with that, I am pleased to turn it over to Berta to lead our meeting.
Thank you, Director DeMorris. And I just want to take a moment to thank all the work that CDA has done and the Master Plan on Aging team for having the insight and the fortitude to do this work. And congratulations on the 5th Master Plan of Aging Release Annual Report. It's extremely invaluable for those of us who are at the front lines working with older independent adults.
Sorry, may I interrupt just a moment? Bailey, your camera is off, so we're not getting ASL. If you could turn your camera back on, we would appreciate that.
The other team, Adrian, should be here. Is he not here?
I don't see another ASL person.
Okay, I just called Focus and they said that he should be joining now.
Can you work until then?
I have to take my daughter to school.
Okay.
I will be back in 10 minutes. I apologize. There was supposed to be another interpreter, and I guess they had to find a replacement.
Thank you.
Thank you.
I'm sorry to interrupt you, Bertha.
It's okay, Carol. May I proceed?
Yes, please.
Thank you. Thank you all for your patience. I'll just repeat salutations. Good morning, everyone. As the stakeholder co-chair, I'm honored and thrilled to welcome our EDJCC members, partners, and members of the public this morning. Our work matters because it strengthens the systems that prevent and address abuse, neglect, and exploitation. Your engagement and participation makes that work stronger. Today, I'd especially like to welcome our new subcommittee chairs, Alicia Morales and Jason Sullivan Halpern. We're grateful for your leadership and partnership. As we move through today's meeting, I encourage everyone to have active participation, ask questions, share insights, and think about how we can move from discussion to action. As we transition to the next slide, I'd like to just remind everyone that EDJCC engagement, there's several opportunities for you to participate, including prioritizing the full council meetings, using the listserv at engage at agingcalifornia.gov, our work group meetings that we'll get into at the later agenda item, the listening sessions that are held, and also the opportunity to connect with fellow co-chairs. Next slide, please. Across a center to everything we do is looking to strengthen the coordination across our subcommittees and across the work that we're going to do together. Before we go into the next agenda item, I'd also like to take a moment to recognize the new EDJCC members that have joined us today. I thank you for being part of this important work. Your presence and commitment to this work will make a big difference. It reminds us of the work of this council matters, and it centers our older adults that we serve to ensure to prevent and address abuse, neglect, and exploitation across systems. I encourage all of you to really engage and make sure that you bring forth the reasons that you were appointed, your valuable experience, your insight, and your expertise. Next slide, please. Now we will transition to sharing about the strengthening adult abuse reporting and response systems, cross-agency collaboration, and systems alignment. During this portion, my fellow co-chairs Alicia Morales and Jason Sullivan Halpern will join us. Before we delve further into the slides, I just wanted to take a moment to provide context for the work the previous members of the EDJCC, who I know some of them are in the attendees list today, so I just want to take a moment for the time and dedication of previous EDJCC members who have brought us to this point in our work. But I want to give new members a clear understanding of and foundation of where we've been and what we're hoping to build. The work of the Adult Abuse Response Committee brings together the three separate committees that are part of the EDJCC. The EDJCC is comprised of our Legal Services Subcommittee, which is chaired by Alicia. Oh, excuse me. The Conservatorship Subcommittee was just chaired by Elisa. The Adult Abuse Response System, which is chaired by Jason, and the Legal Services Committee, which I chair. Together, these three subcommittees operate under the EDJCC to align with the California Master Plan on Aging goals around inclusion, equity, and protection from abuse. These three subcommittees right now are focused on strengthening the response systems that serve older adults and adults with disabilities. Our focus is to prioritize cross-reporting, bring clarity to interagency collaboration, and bridge systematic gaps. Next slide, please. In our previous work with all the experts gathered together, we identified that California is rich in resources and many points to support older adults and adults living with disabilities. However, our rich resources sometimes can create fragmented systems and lead to separate reporting paths that can have that can leave vulnerable individuals without the timely response that they need. So in looking at the problem, we've identified that there's possibly delayed intervention, duplicative investigations, or missed protective opportunities, with sometimes even system experts themselves not understanding or having an appreciation for the different paths that the reporting system can take. Coming together, we realize that a coordinated approach will improve and provide further safety, dignity, and equitable access for older adults and adults living with disabilities. Next slide, please. During this subcommittee, we're currently focused on reviewing those cross-reporting statutes that provide rich resources for our older adults and adults living with disabilities, but looking at the practical gaps that exist, identifying inconsistencies when APS has cross reports to law enforcement, or when law enforcement has cross reports to APS, reporting obligations in long-term care settings, and the warm handoffs that exist between legal services to these agencies. In doing this work, we're examining barriers that exist, including confidentiality concerns and varying interpretations of mandated reporting. The goal is always the goal in the future is to develop recommendations that strengthen our cross-reporting system accountability and consistency statewide. Next slide, please. There's key partnerships, and this is what's so unique and valuable of the EDJCC and why your engagement is pivotal. The promotion of the structured communication between APS, legal services as Title B providers and civil legal aid partners, district attorneys, local law enforcement, ombudsman program, entities, tribal partners, and public guardianship and conservatorship will allow us to explore system solutions, looking, for example, at joint case reviews, strengthening MDTs, data sharing, and how we can optimize warm handoff systems. Next slide, please. As we've stated, one of the main things that we're trying to address are the fragments or gaps that we hear people are experiencing or through our own professional expertise have experienced when trying to make a referral or handoff. Next slide, please. The subcommittee should complete, will continue to do this work. And as part of this work, we ask that the subcommittee contemplate about elevating recommendations based on the discussions engagement. The focus areas will be maybe cross-reporting, state-level guidance, where trainings would be beneficial, strengthening MDT structures where they exist, positioning this work with a broader master plan for aging with emphasis on equity and access for marginalized communities. Next slide, please. In the 3 subcommittees, although each subcommittee has a separate focus, for right now, our work is aligned with the 3 subcommittees collaborating from the legal services, from our APS work group efforts, from behavioral health and housing policy, and the state long-term care ombudsman, with a continued commitment to uplift concerns, bridge gaps, and create improvement and integration. Next slide, please. At this time, I'd like to invite my co-chairs, Alicia and Jason, for further discussion of our current focus at the Adult Abuse Response Committee. Jason and Alicia?
Yeah, I'm happy to get us started. Thank you, Berta. From the perspective of the Adult Abuse Response Subcommittee, our work has focused on strengthening how California receives and responds to reports of abuse and neglect and exploitation involving older adults and adults with disabilities. As we know, these cases rarely involve just one agency or system. Effective response requires coordination between adult protective services, long-term care ombudsman programs, law enforcement, courts, public guardians, behavioral health systems, and so forth. Because responsibility for responding to abuse is distributed across these systems and programs, the subcommittee has been examining several areas where improved coordination could strengthen our response here in California. So I wanted to lay out some of the themes that we've been looking at. The first is reporting pathways. how reports of abuse enter our system. Depending on the setting and circumstance, reports may be directed to several different entities, including APS programs, long-term care ombudsman programs, and local law enforcement, as well as the licensing agencies. For individuals trying to report abuse, whether they're caregivers or professionals or family members, it's not always clear which agency should receive the report. And in some cases, the reports can actually be redirected before reaching the agency with jurisdiction. So the subcommittee has been examining ways on how reporting pathways, examining how the reporting pathways function today, and whether there's opportunities to make that system easier to navigate for reporters. We've also talked a lot about triage and response coordination, how reports are assessed and coordinated once they are received. Specifically, when a report comes in, responders need to determine the urgency of the situation, the setting in which the abuse occurred, and which agencies should be involved in the response. That may involve coordination, again, among APS, law enforcement, ombudsman, and other partners. Ensuring those reports are triaged effectively and routed to the appropriate agencies can make a significant difference in how quickly individuals receive protection and support. And then we're also looking at multidisciplinary collaboration. So many counties rely on strong multidisciplinary teams that bring together these partners, and where these teams are well supported, it can improve coordination, facilitate appropriate information sharing, and help ensure individuals receive the services they need. And I'm happy to say that we're also now beginning to branch out and look at lessons from other states, how those states structure their abuse reporting and response systems to identify potential lessons for California. States have taken very different approaches to intake systems, triage processes, and coordination among these entities. And examining these models can help us identify strategies that can improve clarity for reporting parties and strengthen coordination among responding agencies. These themes all sort of address our larger goal of ensuring that reports are received quickly, routed appropriately, and addressed through coordinated response systems. And I'd like to transition it over to Alicia and our other council members to talk about some of the other challenges that they're seeing and discussing in their subcommittees.
So the work that the long-term care ombudsman does in APS is really critical in addressing abuse and neglect allegations and mitigating them in a less restrictive manner. But ultimately, in situations when there is no other alternative, conservatorship is the alternative of last resort. And in our conservatorship subcommittee, we are focusing on when and how PG ultimately responds. As I mentioned, conservatorship is the alternative of last resort for protection. And from a probate conservatorship and public guardian perspective, we see minimal consistency statewide with unclear pathways to the elder justice system in California. This, along with inconsistent protocols and limited resources, results in vulnerable adults falling through the cracks. Several themes that we are seeing include really basic foundational concerns that lead to systemic inequities in the probate conservatorship system across the state and really the elder justice system as a whole. As you may or may not know, public guardian probate conservatorship is a non-mandated program. So it is resourced differently from jurisdiction to jurisdiction, with 57 of our 58 counties actually having a public guardian's office that manages probate conservatorships. Also, the program lives in various departments across the state, can live in health services, social services agency, or even be a standalone department. This further contributes to the inconsistency and varying cultures within the public guardian's office. And further contributing to the systemic inequities is the fact that, APS does what it can to mitigate the abuse, but without a protective mechanism like probate conservatorship, elder and dependent adult abuse and neglect can go unchecked in one county, while in a neighboring county, it is addressed timely. So statewide, we can see a well-resourced to limited to no outlet for cases where protective issues are identified and conservatorship is identified as the least restrictive alternative to provide protection. PG also has the unique ability and mandate to seek restitution in financial abuse cases, which can be instrumental in positive health outcomes for individuals. Another issue with the adult reporting system is that APS is charged with investigating and responding to abuse in the community, while the long-term care ombudsman is responsible for addressing those allegations in licensed facilities. However, the mandates are very different. Long-term care ombudsman cannot make a referral to public guardian without resident consent, even if a serious abuse allegation is confirmed and the resident is unable to advocate on their behalf, whereas APS can. For all of these reasons and more, conservatorship is often a black box to the entities that normally would make referrals, like APS, hospitals, concerned family and friends. There's also limited and inconsistent capacity for accepting referrals within the public guardian's office, as well as investigating and managing probate conservatorships. Challenges in improving the coordination between these systems is the fact that there is no data sharing infrastructure statewide for PG programs for the courts, which makes it incredibly difficult to track outcomes on a statewide basis. Policy decisions are often made based upon anecdotal stories or whoever yells the loudest. This also impedes the ability to see culturally responsive and trauma-informed approaches. And one emerging issue that is a concern is with the expansion of the definition of grave disability under mandated LPS conservatorship programs and looming budget pressures within counties. Counties are diverting resources from non-mandated programs to mandated ones, further straining the probate conservatorship programs. So are we going to, sorry, I guess I'm going to throw it over to Vivian Mbaku, who will present on Justice and Aging's work on the older adult behavioral health project. No, actually, then we're going to have
On 1 second, let's open for the committee council discussions.
Thank you.
You're welcome. No worries.
Greg.
I think we have a hand raised, Bertha.
Yes, thank you. Greg, would you like to unmute and share your perspective or question?
Yes, thank you I'm a brand new member for about the last 30 minutes, and I'm very impressed by the work you've already done. We've been just in the last few months focusing on some of the mandated reporting issues, and it's becoming clear to us, anyway, that the solution or part of the solution is going to have to involve legislation. My question is concerning the authority of the coordinating council. Can we recommend legislation to the legislature?
We are not a lobbying council. There are specific guidelines that we'll post in the chat box, but our recommendations we can provide system recommendations, which can be shared, and that we can, in our different capacities, move forward with or share with other advocacy agencies to share the insights of the council as a whole. But again, I'm going to refer to the guidelines just regarding any regarding that specifically advocacy and the limits of us as a council.
Okay, as a follow-up question, the findings of the council be such that although the council can't advocate legislation, that they would point clearly to what the problems that cannot be solved except by legislation are?
A great opportunity that we'll also have that we have at these meetings, Greg, thank you for your question, is although we can not put forth legislation, we are at these meetings here with other state and stakeholder co-chairs. And at the end of this meeting, we have the opportunity to summarize the recommendations or the issues that we want to bring to the attention of the secretary. That's the last item of the agenda. So we'll be able to articulate those suggestions or recommendations, and those will go forward to the secretary.
Thank you.
Thank you, Greg, for your question and welcome. Are there any additional new members that would like to ask any questions, or Vivian, our previous co-chair, and then Dan. So Vivian, if you'd like to unmute.
Yeah, I just wanted to add to what Greg was asking about. Even though we can't specifically, advocate for bills here as the EDJCC, we actually, members of the EDJCC, have been able to use the connections that we gained with the council to push forward other types of legislation. So, for example, several members, including Justice and Aging, co-sponsored a bill that adjusted the elder abuse restraining order statute last legislative session, and that was signed by the governor. And those connections were made here at the EDJCC. So I would say, think of the EDJCC also as a networking opportunity and an ability to kind of, broaden your network of aging and disability advocates to use during the legislative session. If there are people that you connect with here, you can talk about, legislation outside of the EDJCC. So I wouldn't feel that like this is like a limiting thing. It's really, it's not appropriate for the council work, but it's something that we can do outside of the council work.
Thank you.
Thank you, Vivian. Dan?
Yeah, thank you. And I appreciate the opportunity to be here. And this is a remedial question, and I apologize for my ignorance. But how do conservatorships or public conservatorships in any way help prevent or attack abuse or neglect in a facility? I'm just so I can follow, with some kind of context in my head.
Mm-hmm. I would say in terms if the abuse is identified while the person is already in a facility and a conservatorship has not been established, it can be challenging for a public guardian to receive a referral. There can be family members that make a referral, but as I mentioned, long-term care ombudsman is charged with investigating abuse and neglect, and by statute prevented from making those referrals unless the resident agrees. There are times when an individual who is conserved already may be residing in a long-term care facility, and that's when public guardian will work closely with long-term care ombudsman when those types of concerns are raised.
And that helps a lot. So basically, it's gaining standing to make the appropriate complaints or referrals on behalf of the patient, of the authority to do it. I appreciate that.
And then we can delve further into that at the subcommittee level. And that's part of what the focus of that work is, to kind of take a deeper dive on those issues. Thank you for your question, Dan. Carol?
Thanks. And thanks for the opportunity to be part of this work. I just wanted to say that another way that the work of this council can be promoted and made public is, especially given all the work that's already done, if the EDJCC's recommendations are included in the next progress report for the master plan, that will make that public, so members of the legislature who are tracking what we're doing can see the enormous amount of work and professional expertise that's going into these committees and this council. So I hope that we can make that happen in the future. That would be great. Thank you.
Thank you, Carol, and welcome as a new member. Tony.
Yeah, I want to add to the benefits other than the legislative piece is that I had an incident as a executive director for a regional center. We had several incidents of fiduciary abuse, and it was very frustrating. And I connected with a lot of members here who had some expertise in that area and understood the sort of the problems in that space, and were very, very helpful in me being able to get a remedy for all of our victims. And we had about 17 victims of fiduciary abuse, and we were able to get them all the justice that they deserved. So that was another positive outcome for me on this group.
Thank you, Tony, for sharing that. A reminder that our connections and just our time together. And I know that myself, when I faced a question regarding a group home, I ended up calling a fellow previous EDJCC member that was in San Francisco, but their quick knowledge helped me solve a local problem. So another valuable way that we can use our engagement together. Dan, did you have another question or comment? Well, thank you, Alicia and Jason, for helping to provide that broad landscape of the work that has been done in the subcommittees last year. Thank you again to some of the members that are participating as attendees, but were crucial in starting that work, especially a previous co-chair, Achilles, for the adult response system. And with that, I will turn it over to Alicia, who I believe is going to transition to our next agenda item.
Thanks, Bertha. Yeah, so now's the time for me to throw it over to Vivian Mbaku for her presentation on Justice and Aging's work on the Older Adult Behavioral Health Project.
Thanks, Alicia. Can you guys hear me? Okay, perfect. It's really good to see everyone today. Very excited for the new members. Welcome. And today I'll just be doing a brief overview of some behavioral health updates for the state of California. And as you see, I have a new position. Previously, I was working on elder justice work with Justice and Aging, and now I am working on California-based behavioral health advocacy, obviously focusing on older adults. Next slide. So just a brief background before we jump into the legislative updates. Why is behavioral health important for older adults? So behavioral health services are really integral in supporting older adults in their aging process and aging with dignity. Older adults in particular face some very specific challenges when it comes to behavioral health. And I will pause for a second because it doesn't look like the ASL. Okay, we got it. Good. So behavioral health is really important. In particular, older adults report really high rates of loneliness, isolation, and depression in comparison to the rest of the population, which is something that we already know. And we also know as elder justice advocates, the risks of abuse and exploitation that are created through that loneliness and isolation. Also, the risk of suicide increases with age, and that risk is highest for people who are 85 years and older. And in starting this work, something that I found really compelling is that drug overdoses and deaths from drug overdoses amongst older adults have tripled in the last 20 years. So there's a really serious behavioral health issue that is facing for that older adults are facing, and some of the factors that complicate getting them services and making sure that they're actually accessing services is homelessness amongst older adults, which we know is rising. The older adult cohort is the fastest growing cohort of people facing homelessness. And then also just issues accessing healthcare services. So the difficulty of navigating multiple healthcare systems, like our dual eligible older adults, people who are on Medicare and Medicaid, and then also people who just don't have health insurance. This complicates their ability to access these services. Next slide. So here in California, in over the past 20 years, we've had the Mental Health Services Act, and in 2024, and the update was passed and signed by the governor. So the statute has changed quite a bit. It's now the Behavioral Health Services Act, which really encompasses two different bills. And the state refers to these two bills together as behavioral health transformation. So there is the Behavioral Health Services Act, SB 326, which has all of the, context, like all the legal stuff about, all the services that are provided, et cetera. And then there's the Behavioral Health Infrastructure Bond, AB 531. And this is the newer part. There's some other new parts in BHSA, but the newer part that creates a bunch of new housing supports that were not existing in the Mental Health Services Act of 2004. Now, this graphic that you see on the right, the state has proposed a bunch of different behavioral health goals. So they're looking to improve for example, the care experience, access to care, quality of life, social connection, and then also reducing with behavioral health transformation, suicides, overdoses, institutionalization, homelessness, etc. So of importance for elder justice advocates and disability advocates is this reducing of institutionalization and reducing of homelessness, and then the increasing of quality of life and social connection. Next slide. So now we have this new statute, the Behavioral Health Services Act. It goes into effect July 1st this year. Counties are preparing plans. We'll talk about the plans in a minute, and ramping up. But I wanted to highlight the eligibility changes. So adult eligibility, there is eligibility for children, but we're talking about adults today. So eligible adults and older adults just means people who are over 26 years of age. So that's really great for our work in particular in elder justice, because there is not this age barrier that sometimes we're facing with other programs where it might be 60 or 65. It's just anyone 26 years or older. And then they need to meet the criteria specified in the Welfare and Institutions Code, or have at least one diagnosis of a moderate or severe substance abuse disorder. And this is a new eligibility portion. This was not in the previous MHSA, the Mental Health Services Act. Next slide. For the Behavioral Health Services Act, there are priority populations as well for the counties. And I highlighted the ones that I think are of particular interest for elder justice advocates and disability advocates. Priority population, that people who are at risk of conservatorship, and then also people who are at risk of institutionalization. So it's really important that these people are prioritized at the county level. We know the risks of abuse and exploitation that are faced by these groups. We were just talking about it. So, very important that they are prioritized for behavioral health services. Next slide. So some notable changes from the Mental Health Services Act to the Behavioral Health Services Act. As I discussed before, the eligibility is expanded. So it includes treatment for substance abuse disorders regardless of the presence of like a co-occurring mental health condition. Another change is that the Department of Public Health is taking on behavioral health prevention services. And as I mentioned, there's the $6.38 billion in funding for housing interventions. So these housing interventions include for the creation of new behavioral health treatment beds and also permanent housing supports. The use of that money will depend on what the county does, individual counties decide to use the money for. But 50% of the housing intervention money must be used for people who are chronically homeless with a focus on encampments. As I mentioned before, there's no specific age range for older adults. It's just that 26 and older. And another highlight, there's no requirement to be enrolled in Medi-Cal. So this is a really expansive eligibility for behavioral health services. Next slide, thank you. As I mentioned earlier, each county, so all 58 counties, have to submit what DHCS is calling an integrated plan. This is a plan that explains how the county will use all available behavioral health funding. So that's not just funding that they receive from the Behavioral Health Services Act, but it would also include any other state funding, federal funding, et cetera. So it will provide a global viewpoint of how the county is going to address behavioral health. DHCS has created a template, and the draft plans are due to DHCS by March 31st. And the final plan is due no later than June 30th. So the final plan is June 30th, and then the actual statute is implemented July 1st and starts. Next slide. So these county integrated plans include a lot of information of interest to us. It will also include information on how they've integrated public comment and stakeholder engagement. There's been ongoing stakeholder engagement over the last year on BHSA implementation. It will also talk about the demographics of the county and how those influence the behavioral health needs. And while we have been talking just about adults, BHSA also covers youth and families. So it will include information about youth and family behavioral health services. Next slide. So looking forward and opportunities for you to get involved. Currently, draft county integrated plans are being released. There is that March 31st deadline, and under the statute, each county is required to have a 30-day public comment period after their draft is released. So we really, this is a great opportunity for you to engage with your county about behavioral health services and how they're addressing older adult needs in behavioral health. So you should check your local county behavioral health website or call your local behavioral health department to ask about information about when the plan is going to be out and when and where you can participate in public comment. Moving forward, the plans are 3-year plans, but there is an opportunity and on an annual basis, so year 2 and year 3, to update the plans, and it will be on the same schedule, so end of March, end of June. And there will be additional opportunities to provide comment on those updates. And the idea about the updates is to allow counties to be nimble and to adjust to the needs that they're discovering as they, move forward with behavioral health transformation. at Justice and Aging, we will be releasing a fact sheet on older adult behavioral health, covering some of this information that I've just discussed today and some additional information. And we are monitoring the integrated plans. Next slide. So these are some of the plans that we've discovered. I think, yes. Okay, so Ranjana just put links to some of these plans in the chat. It's not exhaustive. There's, 58 counties. We're still monitoring and trying to find more of these plans, but we really encourage you to look at your local county's plan for more information on how they're addressing behavioral health. And it looks like Director DeMorris just put in a link to CDA's older adult behavioral health website as well, which is really helpful. Next slide. And then there's some additional resources. The Department of Healthcare Services already has their behavioral health policy manual. That's very helpful in understanding the scope of the work that's going to be done at the county level. And then just the general DHCS behavioral health transformation website has more information on the history of the statute and a timeline and their goals. And I think that is the last slide.
Thank you, Vivian, for providing that update and of this critical work. And I think being on the ground, we certainly have seen the increase in older adults who we turn to legal services for assistance and are dealing with behavioral health issues. This work is not only timely, but is sure to prevent older adults and adults with disabilities from slipping further into crisis. So thank you to you and CDA for the work you're doing on this. With that, I'd like to open it up for questions or comments from the EDJCC council members. Alicia.
Thanks for that overview. That's really, really interesting work. So I just want to ask for clarification that when you mentioned conservatorship in your presentation, that's referring to LPS conservatorship, right? Like mental health conservatorship, not probate conservatorship.
Yes, that's correct.
Okay. Because they're very different referral paths to those two very, very different types of conservatorships. And so like in the work that I've done, and I'm hoping that these plans will address this, but often we've seen with older adults that we believe need behavioral health care intervention, that there is an assumption that the behavior is related to dementia. And so under the Mental Health Services Act, dementia was carved out. And so I'm just wondering, is this addressed in this new act?
Thanks for your question. Dementia is still carved out in that Welfare and Institutions Code for eligibility. This is something that we're very interested in our advocacy and are trying to connect with other advocates about how do we make sure that older adults who may be experiencing a dementia-related disease or not are not assumed that, their mental health symptoms are just dementia and there's nothing else going on. Because the dementia shouldn't exclude them from services if they do have some kind of other mental health issue. So I think this is one of the really important issues. And one of the important reasons that older adult advocates are interested in behavioral health advocacy, because older adults are facing very specific challenges in accessing behavioral health, just by the nature of them being older adults. So thanks for highlighting that.
Vivian, I thought it was very interesting, the age bucket that you highlighted in terms, and surprising that 85 was a crisis point and beyond. At legal services, so sometimes we look at the age buckets too of when people tend to come to us for specific legal issues, and it always seems like there's a surge around 65 to 70 when people have just entered perhaps retirement, and all of a sudden they're navigating new systems or experiencing vulnerabilities after there's not a stable income from employment. And then for 85, we usually tend to see issues that are more related to income stabilization. Is there any, in the work that you guys have seen so far, is there any circumstances that's why that might, excuse me, any circumstances why 85 seems to be a surge for some of those behavioral health needs?
I'm not really sure. I know that stat is from a CDC
Mhm.
study that was done a few years ago. I would assume it's probably, these things that you're mentioning that people might reach a point where, um, they have less retirement funds.
Mhm.
There's additional pressures on them, maybe also additional pressures on their family members for caregiving. And that might be influencing this increase for risk of suicide.
And then I just want to, encourage any of our council members that are also working with older adults that are experiencing behavioral health needs to maybe share out their perspectives. I know for those that work at the intersection of adults with disabilities and older adults, if you'd like to bring forward that perspective. I know as we see older adults, one thing that we've also seen is with our population of older adults with living with disabilities is that sometimes when the older adult that was their caregiver starts experiencing behavioral health need, the older adult with disability sometimes becomes the caregiver.
Mhm.
And there's a situation of like who's taking care of who, and it flips without the proper resource. And perhaps is that something that you've seen any of the plans address, like older adults who are caregivers or um, to somebody who's even to somebody who has their own mental health or behavioral needs, or older adults who um, ex start experiencing behavioral health needs, perhaps because of not have, as I know Sarah just put in the chat, are isolated, might not have the enough resources, and start experiencing caregiver burnout and
Yeah,
behavioral.
caregivers are included in the statute. I think this
Mhm,
is another important thing that we're looking at.
mhm,
It is not fully clear how people are accessing behavioral health
mhm.
services currently and how this influx of money is, more money is always great, but really focusing on how are we actually reaching the people who need
Right.
help. There's obviously stigma when people are dealing with mental health issues. Um, that stigma may be even increased depending on like cultural differences. So I think there's a lot of work to be done around making sure that we're actually reaching the people who need the help the most and making sure that that access to those services is simplified as much as possible. Like I mentioned, there are a lot of issues for people depending on what their healthcare is. Medi-Cal actually has pretty robust behavioral health treatment, but Medicare not as much. And so, and Medi-Cal is I believe the behavioral health systems are kind of split between counties, and access is a little complicated. And we want to make sure that even if the systems are complicated, like the billing systems are complicated, that's not something that the individual patient is having to deal with. That should be something that's on the background that other people are dealing with. And if you are trying to access services, it should be as simple as possible. Very similar to all the stuff we've talked about with No Wrong Door and like trying to make the reporting systems as simple as possible. Really taking that approach to behavioral health and wanting to make sure access is as simple as possible because we know any small barrier can really, for a lot of people, it means, one closed door and they just move on. They give up. They're like, I can't do this. It's too difficult for me. I see Carla has her hand up.
Yeah, hi. I'm Carla Pedicino. I'm a geriatrician and palliative medicine physician. I have too many comments. I'll try to keep them brief. But one of the main comments is actually, I think, around access and terminology. And, we use so much jargon, and frankly, I find behavioral health to be jargony. And I wonder if my patients would actually know to look for behavioral health. Like when someone needs help, they're not using, I need behavioral health help. They're like, I need help with my mental health, or, they're using different terminology. And so I see that a lot as our work in terms of how do we actually use clear language to say what we're talking about. The second comment related to access is that as someone who sees people who are homebound, our homebound adults continue to be a very neglected population. I recently had a patient hospitalized, and when I look back on all my notes literally for the past year are lack of access to mental health care, lack of access to mental health care, lack of access to mental health care. This hospitalization was preventable. I think if we had access for homebound adults, that's very difficult to do, but not impossible. It's opening the right doors, so it's identifying people who are hidden. And as we know, the number of homebound adults is increasing. And then related to that is, the lack of parity in mental health goes a couple ways, in that if with any other discipline as a physician, I can refer to specialty care. With mental health, behavioral health, whatever the hell you want to call it, plans require patients calling themselves. So you have patients who have their own challenges, and you're asking them and putting the burden on them to make the phone call. That is just not just, and it's not okay. And I think so many other doors would be open if I, as the physician or my team, could help be that liaison. That does not include me sitting on the phone for an hour with someone in their apartment to get them connected to the right services. So those are big things to tackle. I don't think they're insurmountable. But, again, as a physician and dealing with the multiple plans, like I don't even know who to freaking call, excuse my language. Like it's very hard to figure out for each person, so then it's like which plan, which medical group, where do they live? Now they're homebound. Do they speak English? And I mean, this is the reality, and I want to just share that reality. So, yeah, that's it. So comments more than questions, I think.
Thank you, Carla, for sharing your insights and those valuable nuances to let us all appreciate the problems from those perspectives. And I think back to what Vivian was saying, so much of it is increasing the visibility and also understanding how individuals communicate and communicate about these issues. And it reminds me of the day of action that we hosted. And when one of the lived experience was like, there's a solution. It just takes me so long to say the name to reach the right person. It's like too many steps. So thank you for reminding us of that important. Ali?
Hi everyone, this is Ali and I'm new. I just wanted to make comments also. Thank you so much for all the work that you all have been doing. The first comment is that, that 85, I am so not surprised as someone who had volunteered on the friendship line for many years. We see a lot of those situations, right? I am actually currently in charge of 3 older adults, 84, 85, and 92. And a lot of people in that age, they have nobody. Every close friend, every family member, they have passed away. So it's we see that a lot. The 92-year-old right now, she's in a sniff, and it's very challenging. It's very challenging to support her because she has a set of way to think. And we just kind of, my friend and I, she's the DPOA for health, I'm the DPOA for finance. We just have to kind of play good cop, bad cop sometimes to support folks, and it's very hard. So many people have nobody in their kind of circle anymore after you turn 85. So I'm not surprised of that, and thank you for sharing that data. My second comment is that when that was brought up that people with disability are caregiver, also the concept of that interdependence is rarely talked about. I think that we strive on independence, and as a person with disability, that's a very ableist way of looking at the world, right? We want to be independent, but we all recognize that we all depend on each other, and that's how the world works. But the idea is we have to be independent, right? So I think that that's something that just really kind of hit me in that thing. I just want to make that comment. The thing also, the last thing is not the comment, it's just a suggestion. I'm having a hard time to do the raise hand, lower hand thing, as someone who is legally blind. So if someone can help me lower my hand, and also to really ask folks when you speak, if you could say your name each and every time, that would be so helpful so I know who's talking. Thank you so much.
Thank you, Ali, for being here. This is Berta Sanchez Hayden, the stakeholder co-chair, and I appreciate your comments and the lived experience that you're bringing forward. It also made me reflect on something that, in a separate conversation, a good reminder that grief is trauma, and that perhaps in that age bucket, what we're also seeing is people that are enduring trauma from losing their loved ones, losing their social circle, and how that can bring an onset of a behavioral mental health need. So thank you, Ali, again, for providing us that. I want to make sure that I didn't miss any EDJCC members or any stakeholders who would like to make a comment before we transition.
Bertha, this is Ranjana. Ali, if you could please come off mute, our CDA staff will support you and accommodate your request.
This is Ali. Yes.
Thank you.
Thanks. This is Carol Sewell. I just wanted to add that the prevention and early intervention services have always been critical through the MHSA. And so I'm curious about how those will be maintained. This is a way to get around the stigma. This is a way to really address people who don't want to reach out, don't know how to go for help or what to ask for. So I'm really hoping that this is a requirement. It's always been a huge fight to maintain those services for the older adult population.
This is Vivian. Yes, CDPH, the Department of Public Health, is taking over prevention services. I really don't have much information for you. It's they're still working on the plan. So when that information comes out, they'll be publicizing it, and we will also be boosting that. So I would say keep an eye on CDPH has a specific behavioral health transformation website, and they'll have more information very soon because the statute goes into effect July 1st. So this is the ball is rolling.
Okay, thank you.
This is Berta. Alicia, I saw you had your hand up.
Yeah, I just wanted to make a couple of comments. I mean, I think we all know this, but insurance does tend to be a huge barrier, and accessing behavioral health care. Don't really have the answer to that, but I'm just wondering if there's some advocacy that Justice and Aging is doing in that area. And then just another comment regarding individuals who tend to be homebound or more isolated, that I think leveraging technology is an area that we really need to further expand and explore. For example, telehealth, which has become much more common now, I think is a good way for people to access these behavioral health care services. And just my own personal experience trying to access behavioral health care services for my children has been very challenging. And as someone who has really worked in this field, somebody who has good insurance and access to technology, as well as the ability, to be out and about in the world, it still is a challenge. So thank you so much for the work that Justice and Aging is doing. And we still have a ways to go, but this is really, really great way to work. Thank you.
Thank you all for sharing your insights. This is Berta. I just wanted a moment for logistics. I apologize for not saying this at the beginning, but during committee discussion or at any time you'd like to make a comment, you can either come off mute or raise your hand for comments. Thank you again, Vivian, for the presentation. At this time, Carol, can we move into our 15-minute break? or may we?
Absolutely. We have 15 minutes, and that puts us, say, 11:15 to 11:30. Would that be work? 11:30. We'll come back.
Thank you, Carol.
Thank you. So feel free to mute yourself and take yourself off video. And when you're ready to come back on, please turn on your video so we know you're back from break. Thank you, everyone.
Great. We'll transition to the next slide then, off of our break slide. Just want to take a moment to thank everybody for the robust discussion under our previous agenda items. It's one of the best things about this council is the dialogue and moving things forward through our shared experiences and expertise. So thank you for your engagement. And with that, I'd like to transition to our next topic and welcome Faye Gordon, our state long-term and care ombudsman. Thank you, Faye, so much for coming today to provide these updates. Over to you.
Awesome. Thank you so much, Bertha. It's so nice to be here. Great to see everyone. I would like to take the opportunity today to introduce myself and a little bit about the state program and provide some updates from the State Long-Term Care Ombudsman Office. And so I'm actually going to be a little bit more informal and chatty. So we can go ahead, if it's possible, and minimize the slides for now. When I do the update one, I'll pull them back up again. But I think it's nice to see everyone and have a little break from slides for a moment. So before I go into an update from our office, I want to explain a bit about how the Office of the State Long-Term Care Ombudsman works within the larger elder and disability justice ecosystem. And I hope you'll indulge me in this. It might be a little bit repetitive, particularly for those of you who are ombudsmen or who have been working in this for quite some time. But I've had multiple conversations with different aging advocates in the past few months since I started this job. I've been in this role for about 5 months now, so still very new. But in these conversations, I've realized many California partners and local partners don't fully understand how the State Ombudsman Office works in coordination to advance local advocacy and works in coordination with local advocates. And I'll be honest, prior to entering this role a few months ago, I didn't fully understand the state's role and the ability of those of us in the State Ombudsman Office to push advocacy and work in coordination and be part of this greater goal of preventing and combating elder justice. I didn't fully understand the State Ombudsman role in that. And this is despite the fact that I've been working in aging advocacy for nearly 2 decades. So I imagine there's some just room for all of us to learn a little bit more about the State Ombudsman Office. So as we all know, the Older Americans Act created the long-term care ombudsman system and really codified it in statute. And here in California, we're fortunate to also have the Older Californians Act that further supports and funds these advocacy services. So these are our 2 guiding laws. And in your area, you may be very well acquainted with your local long-term care ombudsman program. And I hope that you are well acquainted with your local program. And this may be from working together on multidisciplinary teams, might be from collective advocacy that you've done on long-term care issues, maybe from receiving referrals for cases and completing investigations. And so that local program that you work with is actually part of a network of 35 local ombudsman programs throughout the state. And that network of local programs, each of those are administered through a contract with their area agency on aging. And this ecosystem is actually very deliberate, and that this local focus is very deliberate, and there's a historical reason for it. The ombudsmen are an incredible example of a grassroots, locally driven model for change. And this is part of their genesis, part of their founding. It was founded as a neighbor to neighbor advocacy model in New York City back in the late 70s. There was a group of social workers in the late 70s who were working in nursing facilities and realizing some pretty deplorable conditions at that time. And so they created the program and the system that became the long-term care ombudsman system. And so 50 years later, we still have this infrastructure of independent, empowered support at the local level, conducting direct advocacy now for residents in long-term care facilities and in California, increasingly and in far greater numbers, residents in assisted living facilities or RCFEs. And so this is where I want to pull back a bit and introduce our state office of the Long-Term Care Ombudsman and clarify how we work together to support and train this local network of professionals advocating for residents. So we're charged by law, both federal and state law, to designate and certify the local ombudsman, and to do that to ensure programmatic integrity and quality from both the paid staff and volunteers who commit incredible work to this program. We provide training and technical assistance, and we are also tasked with programmatic monitoring and quality reviews to make sure that we are all fully aware of new tools, new resources, new laws to meet the needs of this growing complex population of long-term care residents. But most critically for this group, the state office is empowered to work in conjunction with advocates to conduct systemic advocacy and to really be an independent voice for advocates. So it's a very unique role within the state, and it is not like I'm in this office, I'm the person who gets to talk, but we have an incredible mighty team of 13 state professionals who do this training and advocacy and technical assistance work. So I hope it's okay. I just shared a little bit more about us because I think it can be a little confusing understanding that connection. And now I want to share a bit of an update, if we can bring the slides back up, on some of our progress for the spring. So I want to call out the incredible advocacy of the local programs and Jason, who is on the line, and the work of many of you here that pushed for increased funding to support staffing at the local level so that these ombudsmen, these over 600 paid and volunteer ombudsmen, can be in facilities more regularly and have more of a presence in facilities. As a result of that increased funding, we were able at the state office to distribute funds directly to local programs that directly impacted their staffing capacity. We know that increased staffing means increased quality, and that's because when you increase staffing, you increase facility visits, the more eyes, more presence, more care is going to mean a better resident experience. And so specifically, we just ran all of the numbers. The local programs do incredible work maintaining very complex data so that we can report to our federal funders what we are doing each year. And we found there are now 40 more paid long-term care ombudsman staff in California, meaning that this year we could provide a 5% increase in facility visits. We expect that number will go up, that we will have even more visits as these staff are in their roles for more time and can conduct more access to facilities. So we will be doing some more communications and branding work that we will be releasing throughout the course of this year. So stay tuned for that. But we can go ahead and close out of these slides, and I'm available for questions and really appreciate the opportunity to be here and meet with all of you today. Thank you for your work.
Any committee members would like to unmute, come off of mute or raise their hands. At this time, we can open it up for any questions. Okay. Well, thank you, Faye, for providing us those updates. And actually, it's so inspiring to remember the genesis of the program, of it being a neighbor to neighbor. And I think it's especially important to remember the genesis of some of more long-term programs when we think about systems change and how really at the local level we can. Oh, apologies. Somebody speaking? Oh, and to remind us of the impact that we can have at the local level to make change for our older adults and adults with disabilities.
Yeah, can I just build on that for a moment, Bertha? I've had the real incredible privilege over the past few months to visit think I've been to 12 different facilities and different PSAs. So I've seen the smaller RCFEs and larger SNFs, and I've been out with different local programs. And what's really striking to me is the regular awareness that these local ombudsmen have of the residents. They know their names before they even release the census. They're visiting them for a second, third, time. They're following up on so many things. And as someone who's worked I was at the federal government prior to this, it's fascinating to see a government program that has direct interpersonal human connection with a resident in an ongoing basis. And I can say that there's often no other opportunity for those residents to voice their concerns and share their feelings directly to someone who can have an impact and can actually initiate change, because the ombudsmen have that empowerment and because they are so locally connected with their AAAs and with their counties and with the services. It's just really moving to see these residents have the voice and advocacy activation that they deserve and they would have if they were living in the community, and see the ombudsman be that bridge and the entity to do that. So yeah, thank you, Bertha. Thanks for bringing that up.
Thank you, Faye. Jason?
Yeah, just really appreciate that this was an agenda item, and would be remiss without saying that I think we're very lucky to have Faye as our state long-term care ombudsman. It's a very unique role, and I think for that reason, probably a pretty difficult role to fill. And with Faye's federal experience, being part of the agency that was overseeing the ombudsman programs on the federal level, I think we're going to be in a really good place to develop the program out further in the coming years. So thank you, Faye, for taking on this leadership role.
Thanks. That's really kind. Thank you, Jason.
Jason? I'm sorry, just Dan. I'm looking at you, Dan. Sorry. Would you like to unmute, please?
Yeah, thank you. Faye, I just wanted to reiterate what you were saying. You mentioned the program started in the 70s, and you brought back a lot of memories for me, because my mom was one of the very first ombudsmans, and she used to take me when I was young, and it had to be in the 70s. I knew it wasn't before high school, and she would take me to facilities with her. And a couple of things I remember. One, the smell is still with me from those facilities as a small child. And two, the way that the patients responded to her. They were so happy that somebody was there on their side. And it was, seeing the smiles and the energy and the desperation, it obviously left a mark on me that's still here, when I'm 50, 50 years later. And unfortunately, my mom is now 89 and independent living in one of those facilities now. But it is an absolutely wonderful program, and it also, it's kind of a dual role from what I saw, where you provide the services and you can make referrals as necessary. But it's also, like you said, it is a interpersonal relationship that these people have with people who may have nobody. So I want to thank you for what you're doing, and it's an absolutely wonderful program.
Thanks, Dan. That's really encouraging to hear, and I echo your gratitude to the local ombudsman and the coordinators who are here on the call. And I'm curious where your mom was an ombudsman, where she was taking you.
She was an ombudsman in Santa Clara County.
Oh, cool. Oh my gosh, we have Santa Clara County here. That's awesome. Sourcewise. Okay, so cool. Dan. Okay, thank you for sharing that experience. That's really heartening. Thank you.
Yeah. Well, thank you again, Faye, for those updates and that history. At this time, we'd like to transition to Sarah Steenhausen, who will be providing us an update on the Aging and Disability Lived Experience Advisory Board. Sarah?
Wonderful. Well, thank you so much. This has just been an incredible meeting, and it's so amazing to see all of our new members just jumping in. And we're so fortunate for all of you and the perspectives you bring, and you help raising our awareness at the state level. So I'm really, really excited to be here today with my colleague, Jax Kelly, to provide an update on our Age and Disability Lived Experience Advisory Board. Before I introduce Jax, I just wanted to give a little bit of context for this work. For those of you who were at our California for All Day of Action, which was our big convening with our stakeholder advisory committees and state partners in 2024. We had a lived experience panel at the beginning that really set the tone for the day. And our Equity Advisory Committee on Aging and Disability made a recommendation for an initiative to establish a state level lived experience advisory board to really help inform from the person's perspective how we implement and advance the master plan for aging. So in partnership with our Equity Advisory Committee partners, we were fortunate to get a grant from our MPA Foundation partners to establish the Department of Aging's first lived experience advisory board for the master plan for aging. And to date, we've had 3 meetings. We have 5 more scheduled for the remainder of the year. And it's just been a phenomenal way to kind of reflect from the person's perspective on many of the issues that we talk about in the master plan for aging and that the advocates speak to so well. But again, hearing it from the person's perspective has a very powerful impact on how we view issues. So we have a website that we can post in, you can see in the chat, and we're going to be putting up, video clips of our meetings of the members and hearing from their voices, their reflections. And I'm so pleased to have with me today David Jax Kelly, or who we call Jax, who's president of the Aging and HIV Institute and one of our key leads on the Equity Advisory Committee on Aging and Disability, who has helped us stand up the Lived Experience Advisory Board and is here to present his reflections from the meetings that we've had to date. So welcome, Jax. Thanks for being here.
Oh, thank you, Sarah. And thank you to EDJCC making space for lived experience as real expertise. I'm going to start with one simple idea I heard again and again in our first athlete conversation. Access isn't just whether service exists. It is whether
I'm so sorry, Jax. We're having a hard time hearing you. I don't know if now if you can fix your microphone. It's a little jumbly. If you want to try again.
Yeah. How is it now?
Still the same. It's like a little garbly.
Sorry. I'm really techy on this kind of stuff. So I could try signing off and coming back in.
It might help to turn your camera off. I know that's not ideal, but
let's see if that helps.
Oh, how is his voice now?
Better, much better. Thank you, Jax. Sorry about that.
Yeah. So access, going back to access is whether a person can reach it, understand it, and use it without being worn down by the system. And one participant described the basic act of asking a question and getting help as an endurance test. And I'm just going to pause for a second. Is the sound okay?
It's a little better, but it's still, we're having a hard time. I'm wondering if we can maybe would it be okay if Jax dialed back in or used a phone to call in? That might be the best way to do it, Jax, if you use your phone and use a phone number to connect.
You try that again. Sorry about this.
Carol?
Yeah, my suggestion would be to log off and log back on and see if that just clears out the system. So
why don't you try once more, and we'll just take one moment here to wait for Jax.
Yeah, Jax, why don't you give that a try?
Apologies, everyone. Yeah, if you don't mind, in the meantime, if we could go to the next slide, I want to show a picture of all of our advisory committee members, just so you can get a sense. We were really pleased in developing our outreach for the Lived Experience Advisory Board. We worked closely with our Equity Advisory Committee members to get a very diverse targeted outreach to people from across the state in all areas, representing older adults, people with disabilities, and caregivers from across the state that really represent the diversity of our state. So you can see here, for those who are limited vision, we have older women, African American, from different parts of the state. We have Asian Pacific Islander representation, tribal representation, people with physical disabilities, and also those who have tremendous experience as caregivers. So this gives you a little sense of who is represented. And again, you can go to our website in the link, our Lived Experience Advisory Board website for more information on each of our members. I'm wondering if Jax has joined us again. He's coming on.
Jax, if you are on, come off mute and we'll find you. But I don't see him yet.
Okay.
There.
We will just wait a moment here.
Sarah, can I just comment? I remember the outreach that was done last year to engage individuals with lived experience, and it was so impressive. And I also think it's just an important replicable model that some of us at the locally can learn, because I think at the local level, when we see the opportunities to comment, especially when local AAAs are doing their area plans on aging, that sometimes some communities have great engagement and some communities have lower engagement. So really grateful for the work that was done with this, putting together this committee of what we can learn to further make sure that we keep engagement and consistent throughout the different communities. So we are elevating those voices.
Yes, thank you so much. And we had committed to providing a report out of what we're learning at the committees, at the Lived Experience Advisory Board, to all of our MPA committees, so that we can inform you of what we're hearing, and then you can then provide us with some questions that we can consider when we engage our Lived Experience Advisory Board. And I'm really happy that Jax has returned, and we can start over. Jax, thank you.
Hey, can you hear me?
We can.
You are better,
Okay,
yes.
great. Okay. So I'm just going to start from the beginning, and I just want to start with one simple idea I heard again and again in our first ad-lib conversation. Access isn't just whether a service exists. Access is whether a person can reach it, understand it, and use it without being worn down by the system. And one participant described the basic act of asking a question and getting help as an endurance test. Quote, "I've been sitting on a phone call for an hour just trying to get a hold of someone," unquote. And when the system pushes people to a portal or an app, they said it plainly. If you want to deal with it online, no, that's why I called. Another described being moved from prompt to prompt, department to department, and what they were really asking was simple. Can I talk to a person? That's not just a customer service problem. That's a systems design problem. And it's an equity problem. Because the people navigating these systems are often older adults, people with disabilities, caregivers, people already managing medical complexity, financial stress, or isolation. And when access requires stamina, the system favors those who have the most margin. Transportation came up quickly. One participant put a real price tag on community participation. Quote, "To go to the church is like $30, $60 round trip." Another described shared paratransit routes that loop past your own destination more than once before you finally arrive. Mobility isn't convenience. It determines whether someone remains socially connected, medically stable, and mentally well. Housing came through in two connected ways: stability and the ability to remain at home rather than being forced into institutional settings. We heard from someone living in subsidized housing for seniors and people with disabilities, housing that makes services possible. But we also heard from caregivers navigating medical systems while managing their own health crises. One described trying to coordinate cancer care, dementia care, and disability supports at the same time, encountering delay, redirection, and paperwork at every turn. Caregivers are holding up entire systems quietly, and when access fails them, the consequences cascade across families. And we heard something equally direct about what's at stake when supports aren't coordinated. Not all places have programs that allow people to stay at home, and that means people who could remain in their communities end up institutionalized. When home and community-based services break down, people don't just fall through cracks. They fall into more restrictive, more expensive, less person-centered settings. And fragmentation was another powerful theme. One participant described a clearinghouse organization that works beautifully in their county, and then said, quote, "Not every county has an organization like this, and there's nothing available. Access should not depend on zip code." And one advocate put it bluntly, there are two types of people in the world, people with disabilities and people who are temporarily able-bodied. Aging guarantees that this conversation belongs to all of us. That's why the diversity of the applicant pool matters so much. In reviewing applications for the ad lead, we saw intersectionality everywhere. Older adults who are also caregivers, people with disabilities who are community leaders, LGBTQIA+ individuals on fixed incomes, multilingual applicants, people from rural, suburban, and urban communities. This wasn't a narrow slice of experience. It was California. And that diversity tells us something important. These access challenges are not isolated. They cut across geography, identity, income, and role. So what do we do next? First, we treat navigation as a core service. If someone must spend an hour on hold to get help, we have not delivered the service. A website is helpful, but human navigation capacity and warm handoffs are essential. Second, we must align transportation policy with real life. Not every ride is medical, but every ride determines whether someone remains connected to community. Third, we design housing, home-based services, and caregiver supports as an integrated ecosystem, not parallel silos that require heroic advocacy to survive. AdLib's value is not just storytelling. It is a pattern recognition grounded in lived experience. And if we are serious about equity and aging and disability policy, then the measure of our success will not be whether services exist on paper. It will be whether people can actually reach them without exhaustion, humiliation, or harm. And that is the standard the community is asking us to meet. Thank you.
Whoops. Thank you so much, Jax, for that reflection. And we really appreciate your time on it. If there are any questions or comments, we're happy to hear from the committee members. Thank you.
Thank you, Jax, for such that powerful reflection. So much of what you said seems to resonate with the work of the Adult Abuse Response Committee and what we're seeking to do with, rich in resource, but how these programs are navigated. I was just wondering, again, if you could just state that introductory part of your reflection, just because I think it's so powerful and I think it's so centered to what we should keep in mind as our work moves forward.
Would that be the part where I said access is whether a person can reach it, understand it, and use it without being worn down by the system?
Yes. Thank you.
Yeah.
Alicia?
Yeah, this is Alicia Morales, and thank you so much for that presentation. I think lived experience for so long was an area that was missed in policy development for older adults and people with disabilities. And so it's nice to see it becoming more front and center and more relevant, and that is truly the best way to lead equity throughout these systems. I especially liked what you said about navigation is a service, because it really is the first barrier and ultimately becomes the last barrier to services, because it just stops right there. So navigation is super important. It is the first stop on really a journey to access services and really complicated systems that are not well integrated. And that's really the work that we need to do and continue to do, is integrate these services, become much less siloed. And as Bertha mentioned, that is one of the things that we're looking at in the adult abuse reporting system, is is to try to break down those silos and have one number statewide where people can report elder independent adult abuse, regardless of where it falls in, which jurisdiction it falls in. And it's quite challenging. So, there was some conversation at the beginning of this meeting about legislative changes and legislative recommendations. And so if there's, all of us need to come together and find ways to break down these silos in our forums. This forum is super important because we all become connected here, but then we all leave this and go to other forums where we have influence. And so again, how important this is. So thank you very much for highlighting that work.
Just a reminder that you can come off of mute if you'd like to make a comment or raise your hand. In the meantime, I would just like to share some of the comments that have been placed in the chat. Sarah Hooper notes that this was a powerfully and beautifully put. Thank you so much. Bill Proud notes, well done. And Tony Anderson notes, wow. So thankful Jax was able to get back on the Zoom. This presentation was powerful.
Thank you.
This is Ali. Could I say something?
Yes, thank you, Ali.
Thank you. Yeah, no, I just want to say thank you so much. And it's so great to learn that we have this advisory committee existing. For so long, people with disability, what we say is nothing about us without us, right? And to do this work, we need everybody's voice. People with disability is the biggest minority in the world. And so, doing this work as, I run the Elder and Dependent Adult Abuse Prevention Program with Institute on Aging in San Francisco. And I don't meet a lot of people with disability in the role I am in. So in the meeting, going to conference, I just came back from conference last week, and asking for accommodation was a very interesting experience. It was really great to learn about the different people. And so, when we are, looking at people with what we call the invisible disability, right? We don't see the disability physically. I use a white can, but I'm also chemical sensitive. So to ask for scent-free, it was quite challenging. It was not met. So people like us are not able to participate in the work that we want to do together. So I think that that's something that, the more work to be done. But I really am glad to hear that we have this committee and I get to go and hear more about it and be here in this space with you all. Thanks.
Thank you.
Thank you so much. And yes, Jax is very, very powerful in his communication skills and reflecting on the committee. And he's going to keep getting pulled into these remarks. I tell him he's a victim of his own success. So he's going to be speaking to our other committees as well. And we're so appreciative of you, Jax, and your leadership. And if there's no other comments, I just want to thank you all for your time and for your work and for this opportunity to speak with you today.
Thank you, Sarah and Jax. Next, we'll now transition to the Master Plan of Aging Midpoint Evaluation and Discussion. I'd like to welcome Rob, Lori, and Miranda.
Thanks, Bertha. Hi, everyone. Thank you for your time today. We appreciate the opportunity to introduce the EMPA Midpoint Evaluation. I'm Ross Lallian. I'm the Chief of Research with the Department of Aging, and I'm joined by Miranda Kunkel from Collaborative Consulting, who we're partnering with on this effort. And we're excited to partner with Collaborative Consulting because they bring extensive research experience, have an understanding of the EMPA landscape, and have a strong background in qualitative data collection. So things like designing and facilitating interviews and focus groups, listening sessions, etc. And that's important for this effort because it's about collecting stakeholder feedback in large part. We want to hear directly from the broad network of partners who have helped implement and advance the MPA. And this is a midpoint evaluation because we're 5 years into the 10-year MPA. So we have an opportunity now to reflect on the past 5 years to better understand what's working well and where there's room for improvement to better inform implementation over the next 5 years. We can go to the first slide, please. Thank you. So this slide outlines the high-level goals of the midpoint evaluation. There's going to be a central focus on the MPA's implementation elements, and Miranda will provide more detail on this in just a moment. But essentially, we want to better understand the MPA implementation process to date. And we want candid feedback from partners. So that'll probably include some positive feedback, but also where there's opportunity for development and refinement. So we're going to welcome all constructive feedback, which will help us with the next phase of the MPA. Another key goal of this effort is to raise awareness of the MPA. This is a long-term plan, a 10-year plan. So we feel that it's important to highlight that we're still in the thick of this plan, right? And we're focused on the critical policy issues laid out in the MPA. And we also want to reinforce commitment across our network of partners and stakeholders as we move into the next phase of implementation, especially with an upcoming new administration. And lastly, before I turn it over to Miranda, I want to thank our MPA Foundation partners for their funding support and their continued partnership and collaboration. They've been at the forefront of the MPA from the very beginning and have remained focused on advancing MPA progress. And the MPA remains a strong example of an effective public-private partnership. This council is an example of that. So we look forward to continuing that partnership with this midpoint evaluation. Of course, I'm happy to help answer any questions at the end of the presentation, but Miranda, for now, I'll turn it over to you.
Thanks, Ross. Hi, everyone. I'm Miranda. I'm excited to talk a little bit more about this midpoint evaluation of the MPA. So this slide you're seeing is showing what we will be evaluating, which, as Ross introduced, we are calling the implementation of the MPA. So to define that term, we are adapting an existing framework that comes from the Center for Healthcare Strategies. So these 6 elements that you're seeing on the slide is exactly that. It's this framework from CHCS. So the CDA and the collaborative consulting team have been working on defining and tailoring these 6 elements to really reflect the California MPA context. So I'll briefly just kind of walk through these elements and how we're starting to define them. So first, state leadership. This includes how aware, committed, and invested that state leaders, for example, the governor's office, legislative leaders, are in advancing the MPA. The second element, cross-agency development and accountability. So this includes how CDA and other state partners are sharing ownership, roles, accountability, and collaborating on different MPA initiatives. Third, so stakeholder and consumer engagement. This is not just, is engagement happening, but how is it happening? Is it broad and meaningful and accessible, and looking for examples of how stakeholder input is being used in MPA decision-making. Fourth is data-driven. So this will look at how data is being collected and used for things like tracking progress on the MPA and informing decisions. Living document. So this essentially means how adaptive the MPA is, if it's being revisited, sort of what those updates and refinements look like and how helpful they are, as opposed to being sort of a static document that would just sit on a shelf. And finally, having a broad focus on aging throughout the lifespan. So this includes the extent to which the MPA reflects that lifespan approach to aging, that the MPA really is for everybody. It's not just for today's current older adults. It includes, the future older adults of the world, and family caregivers, people with disabilities, the direct care workforce, intergenerational priorities. So it really is for all Californians. Next slide, please. So we will be evaluating those 6 components systematically with a consistent set of evaluation questions. So this table on this slide is showing what those evaluation areas are and the broad questions that we're hoping to answer. So first is fidelity and progress. So we're trying to answer, how is implementation progressing? Are those 6 elements being carried out as intended? Second, we want to understand barriers, challenges, facilitators, and supports. What's working well, what's not working well, what factors can make implementation easier, and what challenges are standing in the way. This third area, perceived value and awareness. So here we want to understand the unique value of the MPA implementation and what would be lost if they no longer existed. And finally, as Ross was sort of saying, the a huge value of having a midpoint evaluation is that implementation is not done yet. There's still 5 years. So we want to focus a big part of our evaluation on asking stakeholders what recommendations, what areas could be improved for the next 5 years and where should efforts be focused moving forward. So that's where this area comes in. So in order to answer these questions, we will be using both primary and secondary data, which I can talk a little bit more about on the next slide. So this slide is just a high-level timeline for our evaluation. Right now, we're sort of in the tail end of establishing our project foundation, where we have been defining everything we presented today, sort of how we're approaching and defining this evaluation. The core of us conducting this evaluation will be happening in phases 1 and 2. So as Ross said, we are conducting stakeholder engagement for a large part of this. So we will be engaging stakeholders through one-on-one interviews, focus groups, and surveys, and really selecting stakeholders who can speak to those 6 components of the MPA implementation and help us answer our evaluation questions. To complement what we're hearing from stakeholders, we are also going to be conducting some secondary data review to really try to find examples or evidence of the elements of MPA implementation that are relevant to our evaluation. And sort of, it's a very intentional decision to run these 2 phases concurrently so we can sort of continually check and cross-validate what we're hearing from stakeholders and what we are seeing and learning from this document review. So the latter half of our project focuses on analysis and synthesis and kind of next steps. So in phase 3, the stakeholder input and the data review findings will come together into sort of our final evaluation. And we will be looking to prioritize deliverables that are like really succinct, widely accessible, visually appealing, and can be shared across a wide range of stakeholder groups. And again, as Ross said, with a key audience being the incoming administration. So in our final phase, the CDA and collaborative consulting teams will review the results of the evaluation. And again, since there is still time, halfway through implementation, we will be spending a lot of time at this point talking about potential changes based on what we learned. So to MPA processes, content, systems, again, leaning into the unique value of a midpoint evaluation, all in an effort to amplify potential progress over the next 5 years. Next slide, please. So that was our very brief overview of our evaluation, and we would be happy to take any questions or comments from the group.
Thank you so much, Ross, Lori, Miranda. Committee members, please feel free to raise your hand or come off mute if you would like to make a comment. Alicia?
Yeah, thanks, Miranda. That was really great. And I especially liked what you said about the master plan for aging, not just focusing on aging, but also people that are moving into aging. I know it's called the master plan for aging, but I like to call it the master plan for living. Because I think, we all age from the moment that we're born, and the initiatives in the master plan for aging actually benefit everybody and create a community where everybody can thrive as we age together. And there was a comment earlier about interdependency. And I think this really focuses on how much we are so interdependent on each other and creating a community for everybody. And so thank you. And then Ross, you commented about the incoming administration. So I'm just hopeful that the incoming administration sees the master plan for, I was just going to say master plan for living, but the master plan for aging as just that, as something that benefits everybody in the state of California, because the initiatives in the plan actually raise all boats, where we will all be much, much better off. So So thank you both for your work.
Thanks to those comments. I think this is a really important time for us because it's a 10-year plan of living, right? I love that you stated that. That's a long-term plan. We're 5 years in. So I think to raise it right now, all those important issues that you stated, it's an important, exciting project for us at this time. Thank you.
Yeah, and we are implementing the master plan for aging in our county, in Santa Cruz County, along with age friendly through AARP. And we did, under those two initiatives, we did a comprehensive county-wide needs assessment where we included our AAA and we included all of our city leadership. And we were very intentional in that survey to reach out to people age 40 and above. Very mindful that that this is an ongoing process, and we need to be very mindful of the needs of everybody.
I love that. Yeah, these issues aren't going to go away, right? Like 10 years from now, 20 years, it's kind of ongoing issue. So I love that.
Jackie?
Hi, everyone. Jackie Tompkins, Master Plan for Aging Project Director here at CDA. Thanks, Miranda and Ross. What I also wanted to elevate for this group, in addition to doing data collection and speaking with the MPA stakeholder committees, recognizing that the Master Plan for Aging is a whole of government, whole of community approach, we will also be doing the data collection with state agency and department partners, speaking to some of our philanthropic partners, associations, because we're really wanting to do a deep dive into these topics, but also from the various perspectives and lenses that each of those, the collection of MPA stakeholders bring to this project pass, but also its success moving forward as well. So I maybe missed part of Miranda's as I came in a little bit late, but I just wanted to illustrate that you all will be part of something that's collective of additional voices that represent California.
Thank you. And before I transition, I just want to put in a plug again for the great dashboards that are available on the MPA. And I hope that we're all using them also when we talk about lived experience, hearing directly from the voices, but also taking the dashboards that offer important data insights into local communities and all by county. So please continue to leverage those. We also received some, sorry, 1 second. I'm just going to check on a logistical matter. And so I'm going to hold off on that logistical matter. And thank you again, Ross, Lori, and Miranda. At this time, I'd like to invite Jason to lead us through our final agenda item. Jason?
Awesome. Yes, thank you again, Ross, Lori, and Miranda, for the overview of the MPA midpoint evaluation. Really looking forward to contributing to that from the stakeholder perspective. Next on the agenda, we have the council discussion of pressing issues and recommendations to Cal HHS. As a council, one of our responsibilities is to identify challenges and identify systemic challenges and elevate recommendations to the California Health and Human Services Agency. This portion of the agenda gives EDJCC members an opportunity to reflect on what we've heard today, as well as in past meetings, and identify areas where Cal HHS level coordination or leadership could be helpful. These recommendations will eventually be memorialized in a letter submitted to the Secretary of Cal HHS, Kim Johnson. And to get us started, to help frame our discussion, I've sort of picked up on a few key themes from today's meeting that stand out. These include strengthening coordination across adult abuse response systems, improving behavioral health access for older adults, and continuing to integrate lived experience into policy and program design. With that in mind, I'd like to invite council members to share where they believe state-level leadership could have the greatest impact. Some questions that could help guide this discussion are: what issue require coordination across multiple Cal HHS departments? If we were to elevate 1, 2, or 3 top priorities, what would those be? Where could state guidance, policy alignment, or investment strengthen local systems? And are there any local models or collaborations that are working well that could potentially be expanded statewide? And I would, at this same time, encourage council members to frame their recommendations instead of challenges as specific recommendations to move things forward. So for example, instead of saying behavioral health access is limited, we might say something like Cal HHS should explore a cross-departmental strategy to strengthen behavioral health services for older adults, including coordination between aging services, behavioral health systems, and community-based organizations. And I think it's also important that we put equity at the forefront. So are there any particular populations where we could be highlighting in this work? Older adults with disabilities, communities of color, LGBT older adults, rural residents, or even individuals with limited English proficiency. So this is really the opportunity for the council members to get involved in the discussion. We'll have an opportunity for public comment after this as well. So I see, Greg, you got your hand up. Do you want to get us started?
I certainly do. Thank you. My two suggestions both have to do with the criminal justice law enforcement side of the whole problem. The first we've touched on has to do with mandated reporting. That there are many holes in that prevent mandated reporters from, or mandated reports from reaching law enforcement. And with law enforcement, for these are crimes, and law enforcement needs to be involved both statutorily and as a practical matter. So the recommendation would be, can I use the word legislation? Legislation, I just did, didn't I? Legislation to assure that mandated reports reach law enforcement, and the suggestion of one statewide reporting mechanism might be the way to do that, or perhaps not. The other is concerning how well law enforcement is implementing the Senior and Disability Justice Act, which is a comprehensive guidance, not guidance, but mandate to law enforcement for how to handle these things. And it's being, anecdotally, it's been carried out with mixed well, the implementation has been mixed, and we need an evaluation of how well it's been carried out and what needs to be changed to bring about full compliance.
Thank you, Greg. Really appreciate those recommendations. I definitely can speak to the fact that the first, how law enforcement interfaces with the other entities like APS and Ombudsman that are responding to mandated reports, has definitely been one of the areas that we've discussed in the Adult Abuse Response Subcommittee. And I believe we are taking notes on this as well. So even putting the question of legislation aside, even just highlighting that that is still an area where ongoing collaboration could be really beneficial. Really appreciate those comments, Greg. Does anyone else have any other areas?
This is Ali. I do. Yes, thank you. I wanted to bring up this issue. We've seen a lot going on where people are in long-term care. The long-term care facility have changed their insurance. Within Medicare, Medicaid, they changed their insurance so they can kind of, when you pay when Medicaid stop paying, right? And so they changed the insurance for the resident without their consent. And therefore, the resident later on, do not qualify for certain services. We've been seeing a lot of those. And within my program, we're kind of trying to see if we can get some consultation. I feel like this is something that maybe statewide, we can kind of pay attention to that. So just wanted to bring it up.
Appreciate that. Yes, being someone who works closely with the long-term care ombudsman programs, I'm definitely familiar with the type of issue that you're talking about. It's very complex. There seems to be a lot feeding into it. And so I think looking at that closer, how the delivery services interface with these other elements are really important. Thank you. Are there other I know there's a lot of new council members. Don't feel shy. you're more than welcome to participate. This might be your first opportunity to sort of elevate some of these topics to the full council. Carol.
Thank you, Jason. Carol Sewell. One of the issues that we've been trying to understand and have not made a lot of headway with is an issue that we've been identifying as benefits trafficking, the issue of exploitation and abusive treatment of older and disabled adults living in unlicensed room and board situations. And we keep running into the roadblock that all of these things are illegal or they're violations. But the combination of these issues is super harmful and causing death and putting very vulnerable residents at risk. And how do we approach this when there's no enforcement because they're all little piecemeal things scattered throughout both the local, state, and federal, I mean, all three federal system as well. So I don't know if there's a way to at least get that on the radar. It's something we've been working on for a couple of years, actually drafted legislation that wasn't adopted. So I'm just trying to figure out what we do, and I wanted to get input. So thanks.
Thank you for bringing that up, Carol. The issue of unlicensed facilities has definitely been coming up more in our conversations. And I think, like you said, it's an area where cross agency collaboration is so key, right? Because you've got elements of Department of Social Services who licenses facilities. You've got law enforcement responding to sort of the more human trafficking side, and then even agencies like Social Security Administration on the federal level who might be involved in oversight of this at some level. So I think that is an area, I agree, that is an area where Cal HHS could maybe bring some of these entities together. Thank you for elevating that for us, Carol. Alicia.
Yeah, just this is Alicia. So on the heels of that, there is my experience working in 3 different jurisdictions. There is not a lot of consistency, if even at all, training to law enforcement on elder abuse, what it looks like, in particular, like coercion and undue influence, which I think can fall under this benefits trafficking that Carol was talking about. And so it's a recommendation, and I guess also a question when Health and Human Services, when they're looking at these policies and bringing together all of these entities, is law enforcement at the table? And if not, I suggest thinking of the table. Thank you.
Definitely seeing a lot of comments about collaborations with law enforcement. I know we have quite a few folks from law enforcement side of things involved in our subcommittees, but it's always nice to get more folks to the table, and I think that could definitely be one of our priorities if we choose it to be. Any other folks have any topics they want to bring to our attention?
It's Tony Anderson.
Go ahead, Tony.
One thing I don't think we talk about too much in this group is the struggle we all have on getting workers, the workforce shortage problem, and its relation to many quality of life issues, but also health and safety. So I don't know that that comes up enough, but I feel like in most circles where we all are in, that's a common topic. But to think about it in this context as well, that it also threatens the health and safety and also can increase abuse and neglect of people with disabilities and seniors. So,
Thank you for elevating that, Tony. I think speaking for a lot of us working in the long-term care side of things, that is the number one concern and what we see as the number one driver of abuse and neglect is workforce challenges.
you did ask for solutions, so I will.
Yeah,
I do. We do have a bill. Just so that I'm clear, that it's AB 2324 to create a workforce pathway for people with disabilities and seniors for direct support. So it's just one of the solutions on our workforce crisis that we're all struggling with.
I think we should be able to highlight those sort of current efforts to address some of these issues as well, even if we're sort of not making specific recommendations based on legislation. Hi, Sandra.
Hi. So just to talk about the law enforcement collaboration that we're doing in Riverside County. So I'm a senior investigator with the Riverside County District Attorney's Office, but I retired from Orange County Sheriff's Department after 28 years there. So most of my career has always been in investigations with like homicide, sexual abuse, domestic violence, elder abuse, all that stuff. So obviously in my 31 years, I've seen a huge change in how we collaborate with one another, right? Everything used to always be focused on CPS, CPS, CPS. APS was just like a footnote. Like we didn't treat it the same. Now, 31 years later, I see a huge growth and change, but I still see a lot of areas where we can improve. So out here, what we're doing is obviously, we have our elder abuse symposium we do in Riverside County every year where people from all organizations that deal with elders are coming to learn. Every year we talk about mandated reporting, so everybody's hearing it. Myself and two other individuals, one from APS and one from Riverside Sheriff's Office, just got the first post-approved 40-hour elder abuse class that we're going to start teaching in July. And that's post-approved, so we can go anywhere in the state and teach it. And this is mostly for our investigators, and we're teaching them, obviously, cross-reporting and how to handle all types of elder abuse. So we're starting to do that. Obviously, I'm involved in every care group out here, MDT. We're constantly talking with one another. It's getting better. I've always done briefing trainings at all of the PDs and RSO stations, but it still seems like I cannot get people to write an APS report and do a cross report. I mean, I try and try. I mean, I think it's getting better, but like I just had one today where we've been going to this house for 10 years and not one APS report has been written. But they're really good at doing 5150s on the guy, right? But not really looking at the crime part. So I think we need to get law enforcement to open up their brain bigger and look at the big picture and not just look at, oh, this guy's schizophrenic. He's can't care for himself. Let's just 5150 him. Well, let's talk to the parents and ask them why there's spray paint all over the walls. Why are the doors locked from the inside? You know, things like that, right? Because they've been false imprisoned by their kid, and write those crime reports and things like that. So it's just education. And I said this last year, and the last 2 years I've been on these committees, you know, we just got to continue educating. Like when we do it one year, we just got to do it the next year because of the turnover. And that's what I see. That's it.
Thank you. Are you part of the Adult Abuse Response Subcommittee, Sandra?
Yes, I am. Yes.
Fantastic. Looking forward to discussing all of that further with you. If you could bring some of these examples to our subcommittee meetings, it sounds like it could be a great model for educational law enforcement. And Definitely think it's been a recurring theme in our conversation. So thank you.
Absolutely. Thank you.
Moving on to Dan.
Yeah, thank you. I'm just curious get rid of this right here. Is there anybody looking into maybe enabling civil attorneys, especially with long-term care or places that are operating for profit? Maybe making it easier, providing attorneys fees that would motivate a small army of civil attorneys to go out and start suing them and take a little burden off law enforcement where we have limited resources. I think that's another area to attack the problem.
I can't speak much to what like the legal services subcommittee has been working on in that respect, but I really appreciate that. It definitely seems like there could be other ways of addressing this than through the criminal justice system.
I'll just add that, yeah, we look forward to taking a deeper dive from what legal services responses to and from civil attorneys are different than legal services attorneys because under legal services attorneys, we are not permitted to take fee generating cases under OAA or under State Bar IOLTA. So, but there are other actions that we can take. So looking forward to taking a deeper dive. Thanks, Dan, for bringing up that nuance.
Can I just add that, oh, I'm sorry, I don't want to jump in on Greg.
Oh, go ahead, Alicia.
I just want to add to Dan's question. That's one thing that Public Guardian can do is to seek restitution and find civil remedies when there has been financial abuse or perhaps fraud, like someone's home has been unlawfully signed away from them, that kind of stuff. And so one thing that I've said working in this field for now 3 decades is that elder abuse pays. So however we can attack it, whether it be through civil means or through criminal law enforcement means, I think it's important to attack it from all different angles. And then also just Sandra's point, I think there has always been a huge emphasis in training and mandate and resources and everything for CPS. And so CPS is in the home. I think probably more often than APS is. And now as we're seeing many more multi-generational families, I think it's important to pull CPS in because they may be seeing elder abuse when they're in the home addressing child abuse cases. And so I think more cross training with CPS would also be an area that would be helpful.
Thank you, Alicia. I see Greg, is your hand up again?
Yeah, yes, it is. I neglected to mention the other thing. When I think it was 2019 when the master plan was being put together, a number of organizations, including some represented here today, wrote to the administration asking that the master plan include quite a long list of different issues and recommendations, some very specific, some less so. The administration chose not to include those in the master plan, but I've been told, although I've never been able to find it, that there's something in the master plan that says that this coordinating council is supposed to consider those things. So I would like to put those forward as things that to be considered. It's out of date in some ways. There are several things on the list that actually have been accomplished or addressed, but many have not.
I think this is probably one of those opportunities, Greg. So just to clarify, we're not necessarily here recommending initiatives for the master plan on aging. We're just making recommendations to the Secretary of Cal HHS that could be separate from or in addition to the master plan on aging initiative. So if there's anything that you don't feel has been addressed through the master plan or on aging or has fallen off possibly, I think it would be pertinent to bring that up here.
That's what I was trying to say. Thank you. Yes.
I also see Vivian.
Thanks, Jason. I just had two comments. I know Dan made a comment about um, potential civil remedies, and then Berta mentioned that specifically legal services attorneys wouldn't be able to do fee generating cases. One thing that we have discussed, I'm the previous chair of the Legal Services Subcommittee, and we've discussed building up those referral systems between legal services and private attorneys who could actually take those types of cases. Um, and that is something that we've tried to work on. One of the barriers is that there are not a lot of attorneys who are actually specialized in working on older adult issues. So, this is a bigger issue as we have a growing older adult population. We need to not only encourage other types of professionals to, gain more expertise in working with older adults, but also specifically attorneys and uplifting the legal issues older adults have beyond just what people automatically think of, like wills and trusts and estates and things like that, but also expanding beyond that, and really encouraging people at the law school level to be interested in those types of legal issues. Unfortunately, many law schools do not have an elder law class. There's really not a lot of education on older adults, even though we have a really fast growing population. The other comment I wanted to make sure to highlight, like Jason had highlighted earlier, is that, we're talking about using law enforcement and other government agencies, CPS, APS, and it's important to ground ourselves in equity when we're talking about engaging with government agencies and institutions that have historically discriminated against people of color and marginalized groups. And there is an existing resistance in many of those groups to engage with those institutions because of the harm that has been done to their communities. So just grounding all of our work in that and understanding that there may be older adults who are not interested in engaging with those entities for a variety of very legitimate reasons, and making sure that we have other options for people as well.
Thank you so much for bringing those equity considerations back to the forefront, Vivian. I just have been told we have to transition into public comment soon, but I want to make room for Sarah and Dan to make some final comments. Sarah, did you still want to say something?
Thank you. I'll try to keep it brief. Co-signing, sorry, I'm Sarah Hooper, UC Law, San Francisco. I'm one of the new members. Thank you for having me. Co-signing everything that Vivian just said, and coming from the law school, where a lot of our focus is trying to train up a multidisciplinary workforce to care for older adults and their families, it's really important. So just wanted to echo that. But I think I think I might be working with the conservatorship group, so I don't want to preempt any work that's been happening there or that we're doing. But I do want to note that Cal HHS, I think, has been engaged in. I think it would be great if Cal HHS, if the health system side were differently engaged in the issue of conservatorship and could help think about the ways in which data collection that is within the scope of managed care plans, including the Medi-Cal managed care plans, the hospitals, and others could be leveraged to identify people who are at risk for conservatorship and enable us to intervene earlier to prevent the need for that conservatorship. Because where I sit as a lawyer who works really closely with our hospital teams here in the Bay Area and elsewhere, there's a lot of low-hanging fruit. Maybe as a note of hope, I actually think there's a lot of low-hanging fruit that's about like training and protocols and early identification. And I think we can do it. And I think we have networks already that could do it. But and I think the hospitals and MCPs have financial incentives to draw down their length of stay in hospitals and prevent long-term care institutionalization. So I think the systems are aligned, but I would love to talk more about how we could get them from a how do we expedite conservatorship mode to a how do we work together to prevent the need for conservatorship, particularly because it lands most heavily on Black and Brown communities and low-income communities and older women. So to me, it's an equity issue. So anyway, I look forward to working with everyone on that topic. And thanks for considering.
Thanks, Sarah. I appreciate you being part of that conversation. We have one more quick comment from Dan before we transition. Is that okay, Dan?
Thank you. And I'll be very quick. Just on the practical side, a couple of suggestions. If we want to influence law school curriculum and law students' interest in taking those classes, I think an easy way to do that is some coordination with the California Bar Association and getting elder abuse and elder law stuff on the California Bar. And then law schools will start to teach it. And also for practicing attorneys, if you know, you can't be involved in referring cases, but if there's something you could do to provide expertise, these cases are not cheap, right? You're going to need medical testimony, and medical experts are really expensive. If the state had some kind of ability to provide very cheap expert opinion, I think you get a lot more attorneys interested in prosecuting those or pursuing those cases.
Thank you so much for that, Dan. Really ending on a high note here. We will do our best to synthesize those recommendations to include in that letter to the secretary. And at this time, I'm going to transfer this over to Carol to launch into the public comment.
Perfect. Thank you so much. This has been very illuminating and engaging. This is our public comment period for those of you who are online. You can use your Zoom toolbar for your raised hand icon, or if you're attending by phone, it would be *9. And we already have a couple of hands raised, so I'm going to get right into it. Julie, you can unmute your line. Go ahead.
Hi, thank you so much. I only caught this last hour of the meeting, and I'm just grateful to be able to listen to so much that's going on and all the work that everyone's trying to pull together and support, especially of the aging community. I wanted to speak to what Jack's referred to as heroic advocacy. That is indeed what's happening. I'm a nurse by trade over 30 years, but I've also been a primary caregiver for my dad for the past 4, and in community care, the community care area for about almost 20 months. And just has a lot of concerns. I am concerned that the community care licensing portion that falls under DSS, which falls under, of course, Cal HHS, that role of education and regulatory enforcement is very weak, and it really does require heroic advocacy for residents to feel safe and for them to get the care in these facilities that they are paying for. I just wanted to recommend, we have in the regulations guides about resident councils and family councils. But unfortunately, the resident is left to self-advocate. Families are left to self-advocate and attempt to advocate for the resident. And there's a lot of fear there. That there's research on that. There's research that shows that people do not report because they are fearful of what will happen to their loved one. It's out there, well researched. And so I would ask that we do something about really campaigning and finding some support for these entities, resident council and family council, and do some proactive monitoring on how they're functioning. Are they healthy? Are they facility driven where they shouldn't be? Or are they resident and family driven? There is neglect and exploitation happening because we are relying upon the elderly to report and violations of the regulations. So, this is where we really need CCL to be propped up and to have the HR strategy to enforce these regulations proactively rather than reactively. I'll write the rest of my comments. Thank you.
Thank you. Which reminds me, at any time you can send your public comment via email to our Engage email box and be as long as you'd like. Engage, ENGAGE at aging.ca.gov. Nancy, thank you for having your hand up, and you can unmute.
Hi, yes, my name is Nancy Stevens. I've been a long-term care skilled nursing home resident for 6.5 years now, and an active advocate, and also putting myself at risk on a daily basis for advocating for both rehabilitation residents and long-term residents. Again, on a daily basis, I wanted to bring up a couple of things really quick. The conversations about smart glasses being worn in nursing homes. There's a lot at risk there for every party, every stakeholder involved, including the conglomerates, the nursing home conglomerates, because of HIPAA violations and data breaches. But nursing homes are allowing and encouraging direct care workforce to use their meta glasses and cell phones because corporate said when I had my meeting with them about this, about cell phones and meta glasses being used to record and photograph residents, both with their faces and without their faces, depending on the situation. They're encouraged to do so because that's the way the future is going, and we should just deal with it. And this is at Rancho Mirage Health and Rehabilitation Center under the conglomerate of Cambridge Health. And also wanted to talk about the people who are in charge of our care, social work, for instance, where in caseworkers and activities directors, activities staff, where the residents trust and spend a lot of time and depend directly on these people for their help or for their care, are willfully and knowingly lying to residents and rehabilitation patients. For instance, and I've gone through every single tactic you can even imagine, including most recently my health information being sold to a third party, where they stated that they were here and provided care for me when I was not even in the building all 6 times. And so there's a fraud investigation. Hopefully that was opened by them. But I
Nancy,
wanted to talk about
if you could
knowingly
wrap up,
lying.
if you could wrap
Yeah,
up.
sure. So a lot of these things like patient dumping, for instance, happens every Friday, where patients are being told their insurance is no longer covering their care. And residents go ahead and trust that that is true and panic. And they come to me for help. And we should have some sort of ability to have like an alliance that works directly with the ombudsman program for what might be construed as a smaller, less harm issue.
Okay. Thank you for your comment, Nancy.
Of course, thank you.
This is the public comment period. If there are others, please use your raised hand icon, or if you're on phone, it would be *9. A note, we have 2 minutes for each public comment. And of course, at any time, you can send your detailed or any comment to our Engage email box at engage, ENGAGE, at aging.ca.gov. Nancy, do you have another comment, Nancy?
Yeah, just really quick, also like to add that Riverside County here in the Rancho Mirage Palm Desert, Palm Springs area, law enforcement is used by the social work and the interdisciplinary teams to intimidate nursing home residents.
Okay. Thank you for your comments, Nancy. I don't see any more comments, any more raised hands. There's that, and our director.
Thank you, Carol. Director DeMorris.
There we go.
This was a fantastic meeting. I'm just so energized by the addition of our new members, and we didn't skip a beat because our continuing members and our new members have just enriched the conversation. Thank you all, and excellent facilitation, Berta.
Thank you, Director DeMorris. Well, once again, I would like to thank everyone for their participation. What a vibrant meeting. I think all of us together have such combined expertise, but together we're even stronger. And I want to again thank the individuals that brought forward the lived experience to ensure that it's always central to our work as well. I still haven't caught my breath from those very powerful words that Jax shared with us. And I think as service providers, are in our roles outside of EDJCC, it reminds us of the responsibility to ensure that all of our services meet that accessibility and are not causing endurance issues. I'm looking forward to seeing you all at our next EDJCC full council meeting. Please look out, new members and continuing members, for emails regarding our subcommittee work. Thank you again.
Thank you for joining. The next meeting is June 11th at 10 a.m. And of course, we will have all materials posted on the EDJCC Cal HHS, California Health and Human Services webpage. And again, thank you all for joining us, and we appreciate our chairs facilitating. And of course, always stay connected on our various connecting social media platforms. Thanks again, everyone. Have a great day.